All right, kinesiology 3030. We're back with the rest of the lower extremity. Hopefully you got a lot out of the first lecture. Try to condense it a little bit more so that you're not watching for too long. Keep you engaged a little bit better maybe. But now we're going to go distal to the knee. We're going to go look at the ankle, the muscles of the subtalar joint, metatarsophalangeal joints, and interphalangeal joints. And we'll get into, again, how they relate to posture and postural control. Okay. First muscle we'll talk about is gastrocnemius. This is our large calf muscle. Okay, they have its origins on the femoral condyle, so technically it is a knee joint muscle, especially for the initiation of knee flexion. However, it's most often thought of and trained and used as a ankle plantar flexor. It has its insertions via the Achilles tendon with the rest of the calf complex at the calcaneus. So kind of the heel and that Achilles tendon. Okay. At the knee, it can perform knee flexion. It's going to be a synergist for the hamstrings. It often works as a stabilizer for the knee joint during more dynamic tasks, and plantar flexion, especially during knee extension. So if we are in a knee flexed position, we limit the involvement of gastrocnemius, that biarticular structure. If we shorten it at the knee joint, we lose control at the ankle joint, and it will act more at the knee. If we keep a knee extended position, we can use gastrocnemius for plantar flexion to a greater extent. So that's why activities with triple extension, or where we extend the hip, extend the knee, and then plantar flex the ankle, get so much extra force production, because we can use the gastrocnemius, because now once the hip is extended, the knee is extended, and last the ankle is plantar flexed, gastrocnemius becomes more involved. So activities like jumping and sprinting, because gastrocnemius is extremely strong and it's often more of a fast twitch dominant muscle, we can get more explosive movements there using gastrocnemius. But most often when we're plantar flexing the ankle, we're using soleus. It has its origins posterior on the tibia and the fibula, and an insertion on the calcaneus deep to gastrocnemius on the Achilles tendon. This makes up the bulk of the calf musculature and is an extremely often slow twitch dominant muscle, because it is there for ankle plantar flexion, often during walking. When we walk, we have to plantar flex the ankle, but often the knee is flexed while we're performing that plantar flexion. Soleus is going to be extremely dominant there. And it is predominantly made through the Achilles tendon, which we get a lot of that stored elastic energy. And so its function is plantar flexion, nothing else. It doesn't cross the knee joint, doesn't cross any other joints. It is only an ankle plantar flexor. Think of it as our true plantar flexor. Okay. Moving anterior, okay, we talked about the posterior, the plantar flexors. Now we'll talk about tibialis anterior, which has its origins on the tibial condyle, and also a little bit anterior on the tibia, and an insertion on the first cuneiform at the base of the first metatarsal. So it moves from lateral proximal tibia to medial at the first cuneiform base of the first metatarsal, proximal metatarsal. So it works to assist in two joint movements. So we get ankle dorsiflexion because it crosses anterior to our tibiotalar or talocrural joint, and it crosses the subtalar joint laterally and can cause inversion, or bringing the plantar aspect medially, or the plantar aspect, the bottom of the foot, medial or towards the other foot. This is often the muscle that is fatigued during walking and running, because if you land with a heel strike, or your heel hits the ground first before the plantar surface, you have to eccentrically resist plantar flexion. Tibialis anterior is the muscle that does that. It is primarily tendon and extremely fusiform, so it works very well for eccentric actions. But if maybe you started running or started running recently, or during high school or some other time you started training, started your conditioning for your sport, started running, started walking a lot, and you've developed something like shin splints or anterior shin pain, it's often linked to tibialis anterior and gastrocnemius not working together well as agonist-antagonist, or weakness in tibialis anterior, not being able to resist that constant plantar flexion, that eccentric plantar flexion. tibialis anterior has to be strong enough to resist that action. So best way to train is often walking, and walking with that heel strike, walking downhill. If you've ever gone hiking, the way back is much harder running downhill because you're constantly having to resist that plantar flexion. Tibialis anterior is often extremely used in those activities. Okay, if we look lateral across the ankle, we have our peroneal group, Peroneus longus, Peroneus brevis, and Peroneus tertius. They have their origins lateral on the fibula. So think of these as their lateral ankle muscles, and their insertions on either the fifth metatarsal, where brevis and longus have their insertion, and tertius has its insertion on the dorsal surface of the foot, near the fifth metatarsal. Okay. Their actions are eversion, so think of these as the muscles that allow you to evert or resist inversion. So these are often the muscles that are fatigued or damaged if you're constantly cutting or changing directions, or if you're maybe doing something like ice skating where you're moving a lot of lateral movement where you're everting to propel yourself forward, or if you roll your ankle and this muscle has to resist that inversion, non-wanted rotation. So they work for inversion, or they work against inversion, cause eversion. They can work for plantar flexion, and tertius will work for dorsiflexion. So our lateral peroneals, Peroneus longus, Peroneus brevis, will cause plantar flexion also, but Peroneus tertius will assist in dorsiflexion. It's kind of the lateral dorsiflexor, while tibialis anterior is the medial dorsiflexor. They'll work as synergists, but tibialis anterior will be the prime mover. Peroneus longus will be the prime mover for ankle or subtalar eversion. If we look at tibialis posterior, another small, deep plantar flexor, has its origin on the tibia and the fibula, a posterior, and it's deep to soleus, and an insertion on the navicular and first cuneiform and also on the metatarsals. This works, kind of think of it as an insertion on the plantar surface. It works to create that arch, okay, that medial arch of the foot. We often see weak tibialis posterior in people who are extremely inactive or aren't going out very much, aren't running, aren't walking, or if you have an overused or weak tibialis posterior, you lose that arch very quickly. So it works as a synergist for plantar flexion, synergist for inversion, but really it's there to support the body weight and create that stable arch so that we can maintain posture above. A great way to train it is doing short foot exercises. This is where you lay your foot flat and try to bring your distal foot, or bring your metatarsals, the heads of your metatarsals, towards your calcaneus. Try and shorten the foot, try and lift your arch up. Try it right now, just pause your video, look at your foot and try and bring those two together with your foot flat on the ground. Nothing may happen if you've never done them before. I recommend trying them out. Maybe you can look up some extra videos and see how to do it. But this will improve tibialis posterior control and can improve foot health and foot posture. If you constantly have foot pain, you may want to train tibialis posterior. Okay, now let's look at those interphalangeal muscles. Okay, we have our flexors, which have their origin posterior on the tibia and the fibula, and then their insertion on the plantar surface on the individual bones that they move, or those distal bones that they move. Similar to how we have muscles that cross anterior or flexors in our hands, similar when it comes to flexors in the foot. Okay. Flexor digitorum is a interphalangeal flexor, and flexor hallucis longus is a great toe flexor, your big toe flexor. It also helps to maintain that arch as well. So training flexor hallucis longus and tibialis posterior can work to create that nice stable arch. I recommend doing as much foot strengthening as you can, because often the foot is neglected because we keep it in a shoe all the time. If we look at those flexors, if we think about their actions, flexor digitorum, flexor, and it crosses medial over the ankle, so it is an inverter. Same with flexor hallucis longus, they're inverters and flexors of their individual interphalangeal and metatarsophalangeal joints. If we look at the extensors, we have extensor digitorum longus and extensor hallucis longus. These are the only ones we'll talk about. They have their origin on the fibula. This is where fibula injuries often cause some major issues because it is a major origin point for a lot of our lower leg muscles. Their insertions are on the distal digits. Extensor hallucis. Hallucis, similar to pollicis for the thumb. Hallucis is the great toe. Will extend the great toe, and they're also anteriorly crossing the ankle joint, so they will assist with dorsiflexion. Extensor digitorum longus can also help with eversion because it is slightly lateral, and extensor hallucis longus can help with inversion. So we have a few inverters, a few everters to help stabilize, and they often neutralize each other's action when we're performing plantar flexion and dorsiflexion. So how do these all cause pelvic rotations if they're all distal down at the foot? I started out this lecture by talking about how these may affect the lower leg can affect pelvic rotations. If we have an overpronated foot, or if we have this dropping of the arch, think lack of flexor hallucis longus strength and tibialis posterior strength or control, will cause the tibia to rotate inward. Tibial inward rotation causes the knee to move inward, or causes adduction and internal rotation at the knee, which can lead towards anterior pelvic tilts. So think if someone is constantly sedentary, they also have tight anterior hip muscles, and then they have poor foot control. This can also lead to poor pelvic control as well. So training kind of from the floor up, from the foundation upwards, can also benefit your pelvic control and your your more proximal, your trunk posture. I recommend trying it. Start feeling the ground. Start thinking about how your foot is functioning, or maybe how the people you work with, if you watch their foot start to collapse, you may see the tibia and the femur rotate in, and the pelvis dump forward and laterally. These can all cause dysfunctions, can cause pain, can cause wear and tear, especially here if we have this overpronated foot, may lead to early progressions of things like osteoarthritis, and also pelvic control can lead to pain in the back, can be from changes in the foot. I recommend foot strengthening and motor control strategies. Start learning how to control those muscles before moving to things like orthotics, because orthotics are kind of masking that problem. So foot strengthening first can really cause a chain upwards and control more of those proximal structures. All right, thank you for watching this video. Our next video will go through a movement analysis of the lower extremity through walking. Your lab 16 will be a movement analysis through walking, so I recommend kind of linking those two videos together as you're completing, or linking the video and linking your lab together as you're going through. All right, thank you very much, and I'll see you next time.